invite Dr. Mathew James again for his talk on cranial neuropathy.
I'll be speaking to you on cranial neuropathies and brainstem lesions. I'll get into the case straight away. I'll be talking to you about 4 cases. 2 cases will be about brainstem lesions, and the other 2 will be on cranial neuropathies. The first case is 35-year-old male with acute onset visual disturbance. On examination, he had diplopia on looking towards the towards the left side. He had a limited adduction of the right eye during levoversion. He had a near normal convergence in the same eye. Diagnosis is pretty straight. You can see the clinical pictures. All other eye movements are normal, except for the right eye, the adduction has been lost. You can see that highlighted area. So definitely this is an INO clinically. This is the convergence. You can see, I'll show you the convergence. The eyes can better converge onto the pen actually when the patient sees the pen. So it's a very simple case. It's an internuclear ophthalmoplegia, and you know that when the medial longitudinal fasciculus is involved with a lesion, the information from the PPRF doesn't go to the opposite medial rectus, and as a result this symptom is shown. But the thing which I would like to highlight is there are 2 innervations. One is a pulse innervation and the step innervation. So what we are dealing now in the first case was a pulse innervation. That means the pulse innervation which was sent to the opposite medial rectus and the lateral rectus was not possible. It was not being fired, and as a result he developed the INO. Now what happens, there is one more center in the pons which actually has to maintain the saccade. Once the brain sends the information, look towards your right side, the right lateral rectus moves, the left medial rectus moves. So after reaching that position, the brain has to maintain that saccade, and that is done by another center. Usually we don't get lesions of that area, and it is done by actually nucleus prepositus hypoglossary. So what will happen if that center is involved? That is my second case actually. This was a 73-year-old male who presented to emergency with acute onset weakness and difficulty on looking towards the left side, and he was diagnosed to have an acute left pontine infarct from the casualty itself. His eye movements were perfectly okay. He was able to move everywhere. I didn't find any diplopia or anything. But and this was the imaging. He showed an infarct in the left pons. But actually, when examining his eyes, you can see he's not able to maintain his gaze. He's trying to move his head and maintain the fixation towards the left side. He initiates the saccade, then again loses it. When he looks to the other side, he's able to do that. So that was this is what happens if the nucleus NPH is affected. So he will be able to initiate the saccade, but he will not be able to maintain it, and as a result, he will have disturbance of vision. And the same thing can happen in the vertical gaze also. That is when INC, the nucleus of Kajal, is affected. That also can cause similar kind of symptoms towards the vertical gaze. Now the third case is a 18-year-old male who presented to the OPD with history of diplopia and headache. He had associated photophobia and migraine. His vision was 6/6, no RAPD. He had a right third nerve, sixth nerve, fourth nerve, all were affected. And in addition to that, he had a decreased corneal sensation of the left eye, and the sensation of the face was also found to be decreased. So the possible diagnosis was when these many nerves are affected, it has to be either the superior orbital fissure or the anterior cavernous syndrome. And definitely, and the imaging also actually was corroborating to that. You can see a large lesion in the left cavernous sinus, which was causing all this problem. The MRI with contrast was done, and it showed these lesions. Angiography, and definitely whenever you have such lesions, always do an angiography to rule out aneurysm also. The investigations was done, the blood investigations were sent, all were negative. Meanwhile, he was started on steroids and he improved drastically with the steroids. We had planned a biopsy, but since the patient had improved, he deferred from taking a biopsy, and this is the patient after 2 weeks post-treatment. So you can see his movements have completely improved. So one thing that I would like to highlight is always do an MRI, contrast MRI, and check for the trigeminal nerve whenever you're having multiple cranial nerve palsy, because it might help you to diagnose whether it is an anterior cavernous syndrome or where the lesion is. Now the fourth case is a similar case itself. The 55-year-old male who was referred from periphery as acute LMN facial palsy and exposure keratitis had undergone tarsorrhaphy elsewhere. On examination, he was found to have again a right third nerve, sixth nerve, and a fourth nerve paresis. He also had facial numbness, absent corneal sensation, and in addition to the previous case, it was just like the previous case itself. In addition, he had a masticatory muscle weakness, which you can just ask him to drop his jaw and check the muscles weakness. So in this patient, you can see the clinical picture. He has all the 7th, 3rd, and 6th affected. The 4th, it is not visible on the photos. On the imaging, he had a large lesion on the actually arising from the trigeminal nerve and compressing onto the pons basically. So it was diagnosed to be a METS. Later on, it was diagnosed to be a METS basically. So the point I would like to highlight is, whenever you trigeminal nerve is I think should be a basic test which we should do to whenever we having multiple cranial nerve palsies, because it might help us to localize the lesion actually. So that is the point I would like to highlight it. Thank you.
Thank you very much, Mathew.